Subcommittee.
Sorry about that. I forgot to start that soon enough. Thank you, Laura, for the reminder.
Okay, next slide. So I am a state employee at UNR, and Lisa is also an employee at Washoe County. And so we just want to make clear that what we're talking about today are a product of our own opinions and views and statements. We're not speaking on behalf of our representative organizations, and are limited by the way in which we can talk about some things because of the nature of our employment. Next slide. I don't need to tell you this, but I want to think about the frame in which we are thinking about overdose at this moment. Everybody knows that we have been dealing with and enduring opioid overdose crisis that has evolved over the past many years. It sort of got on folks' radars maybe 5 or 6 years ago, but this is something that as a nation we've been addressing for at least the past 20 years. And you've all seen the headlines enumerating the number of deaths in the past 2 years, reaching over 100,000. Some new data from our Overdose Data to Action group has been looking at changes in death rates in Nevada. And so I just want to point out two things from one of their recent analyses. One, in 2020, we saw a 54.5% increase in deaths in Nevada. And the largest increases are among Hispanic persons. And so this is something that does not surprise us, but is worrisome, and that we should be paying attention to in terms of how the crisis is evolving and how subpopulations are shifting and who is in need and who is at risk. And the other way that I want to frame how we're thinking about this is just to say, this 54% increase is occurring in the presence of and despite massive investments in naloxone distribution, treatment scale up, and prevention initiatives. We are working very hard to address this problem, but what we're doing is not enough. And we need to be doing more, and we need to be more thoughtful about how we're addressing the crisis. This is also happening in the context of an evolving drug market, including fentanyl and xylazine and new contaminants in the drug supply that are making it more and more risky for everybody who's out there engaged in the illicit market. And to me, as a public health researcher, what this all says is that we need to scale up our focus to social and structural determinants of overdose death, policy level determinants of overdose death, and think about ways in which we can address those social and structural barriers. This is not an individual behavioral problem. This is a structural and a systematic and a policy problem. And we need to use those levers to get more benefit from the interventions that we've already deployed. So we've been asked, next slide, please. I'm flipping my own on the side here. So we were asked specifically to talk about, and Lisa and I could talk about these issues forever, and we would love to bend your ear forever, but we are really going to try to stay on target today and talk about this issue of Good Samaritan laws on the one hand and drug-induced homicide laws on the other. So in 2015, Nevada engaged in the process of developing a Good Samaritan law. There was at that point a long history of these types of laws. The first was in New Mexico in 2007. And Good Samaritan laws, 911 Good Samaritan laws, were put in place in response to a very well-known fact, which is that fear of legal repercussions when calling 911 is a significant barrier to seeking emergency medical care when somebody's having a drug overdose. When somebody is having a drug overdose and there is a bystander present, that bystander is faced with an impossible choice to call 911 to help the person who's dying in front of them and possibly risk law enforcement involvement and all of the legal and social fallout that can result from that. And that includes both criminal charges and the other kinds of social repercussions, things like threat to housing, things like threat to child welfare. There's a whole set of concerns that come with making that decision to call 911 every time you're faced with this life-threatening emergency. And so Good Samaritan laws were put in place to address those concerns by providing limited legal protections to callers and victims when they call 911 to get emergency medical help for an overdose. And in part, this problem is because the emergency medical system and the law enforcement system are tied through our 911 dispatch system, right? When you call 911, even if you're just seeking emergency medical care, there is a chance that you will also create a law enforcement response, and you don't get to choose as the caller whether that happens or not. As of 2020, there were Good Samaritan laws in 47 states and the District of Columbia, and there have been some national level evaluations of these laws where they're looking at implementation of these laws and showing a 15% reduction in overdose deaths in communities after the implementation of a law that is designed to protect callers who call 911 in the event of a life-threatening medical emergency of an overdose. Laws vary across states. There are some very good analyses done by the Network for Public Health Law that looked at the different provisions, but we know that laws that protect from arrest are more effective than just those who only include charges for lower level offenses. So just for your reference, this is Nevada's good, oh, next slide, please. Just for your reference, this is Nevada's Good Samaritan Law. As I said, it went into effect in 2015. I was very lucky to be part of that process. And our Good Samaritan Law and our naloxone access law were part of the same bill and the same reform, which was great for Nevada. At the time, these were some of the most comprehensive laws that had been passed in the US. Next slide, please. And what we've been asked to do today is to contrast or think about the intersection between those Good Samaritan laws and drug-induced homicide laws. So as I said, Good Samaritan laws have been on the books in some states since 2007. They are now on the books in almost every state. We are seeing a national trend towards enforcement of drug-induced homicide laws. So these are laws that criminally implicate people with manslaughter or homicide charges who sell or provide drugs linked to an overdose fatality. And I'm sure that you've seen these in the news. We've seen several high-profile cases lately. They're increasingly being implemented as a reaction to and a response to fentanyl contamination in increasing deaths. And the rationale is deterrence. They're framed as a mechanism to target high-level dealers, to put drug dealers on notice and nudge them away from illegal activity. And the operative mechanism in these laws is the severity of the punishment. So the idea is if you provide drugs to somebody who dies of an overdose, you are liable for that death. As of 2019, about half of all states had such laws, and the most extreme versions prosecute drug-induced homicide under first-degree murder provisions, punishable by life in prison, and possibly the death penalty in some states. Next slide, please. Research on drug-induced homicide laws is also ongoing, and what we understand is that they increase fear of calling 911. So now imagine you are that person who is faced with somebody having an overdose in front of you. You're trying to decide if you're going to call 911 to save their life, but you're considering the risk to yourself and them and your family of having a law enforcement response. And now you're also calculating the likelihood that you might be prosecuted under a drug-induced homicide law. So these laws actually subvert the intentions of Good Samaritan laws. They decrease the willingness of people to help during an overdose. And what we also know is that these kinds of penalties do not deter substance use or distribution, right? They are designed as a mechanism to get after high-level dealers, but that's not what they're doing. And what they're doing instead is frequently catching friends and family of the decedents. Next slide, please. So these are results from an analysis done by Leo Beletsky, who is a JD MPH public health lawyer, and he looked at online news reports of prosecutions of drug-induced homicide cases. And what this graph is showing you is that 40% of these prosecutions for drug-induced homicide actually picked up caretakers, family members, friends, or significant others of the decedent. And so the people who are getting caught up in these laws are often the lover or the partner or the wife or the caretaker of the person who was there who happened to be having the drugs, but they were not a high-level dealer. They weren't somebody that was up in the cartel. They were close family members or friends of the decedents. Next slide, please. Oh, yeah. So just for your reference, this is the law that's on the books in Nevada in terms of our own drug-induced homicide law. I don't have the effective date, but it is not new. I don't know if you remember, Lisa, and you can say. So this is Nevada's law that includes penalties for making available controlled substances which cause death. And provision is selling, giving, trading, or otherwise making available. And you can see the rest of the provisions, and you can note the NRS number here. So I'm going to hand it off to Nevada or to Lisa now, because we're going to transition to some data that our team has collected and that she has collected as part of her work and her own experiences to talk about how these conflicting messages impact the lives of people who are using drugs and are witnessing and experiencing overdoses.
Thank you, Dr. Wagner. As Dr. Wagner stated, some of the quotes on your screen here are from Dr. Wagner's own research. And again, these experiences that I share are my own. And if I could, just as a person in recovery, I would like to mention how I experienced some of these laws, right? As someone who experienced almost a dozen reversed overdoses, which is why I'm here presenting to you today, none of which did anyone around me ever call 911. I will say that in 1996 in New Jersey, I did have somebody call 911 for someone whose overdose was very difficult to reverse. And I literally hid in the bushes. Other folks at the scene were like, "You've got to get out of here." And I was so afraid. I wanted to know if this person was going to live or not live. This individual did live, but if circumstances were different, based on the drug-induced homicide laws on the books in New Jersey in 1996, I'm not sure what that current policy landscape looks like today. I was a scared 20-year-old in the bushes, and by my math estimates, I would still be incarcerated in prison, and not a tax-paying citizen contributing to the betterment of my community or working on a doctoral degree. So I just want to mention the real impacts that people have at me as a person, as well as the folks in this research. And I do want to mention that currently in the landscape, we're starting to see an uptick of what people are calling do not prosecute advance directives. And what this means is that people who use drugs are signing off on these do not prosecute advance directives, basically saying, if I should perish because of my substance use, please do not prosecute people that may have sold, traded, bartered, etc., me drugs. So we're starting to see that. Next slide, please. And then again, back to the research on this topic, I do, again, want to reiterate that Leo Beletsky teaches, he's a health law professor at Northeastern, and he also teaches at the UC San Diego Medical School. He's written a toolkit for sort of people involved in the legal system around drug-induced homicide laws, and I'd be happy to share that with anyone. And he found in his research that was published in 2019 that drug-induced homicide laws disproportionately impact people of color. So they tend to have inequities around incarceration there and create further mistrust and calling for help in the event of an overdose. And what we're seeing nationally, which mirrors, what we're seeing in Nevada also mirrors that trend nationally, that we are seeing an increase in Black and Hispanic fatal drug poisonings. And so again, we're at this sort of intersection between treating overdose as a crime or treating overdose as a public health crisis. And so are we using public health strategies to address the opioid crisis, or are we further creating disparities with our incarceration and criminalization? He also stated that policymakers, prosecutors, and the police have continued to draw on the arsenal of carceral and punitive tools in mounting the response. These actions reflect established dynamics of policy theater where public figures trend towards actions that are visible and noteworthy regardless of their ultimate impact. That is found again in that 2019 publication, page 883 to 884. And what he recommends is to reduce stigma and revise the Controlled Substances Act. And he also says, I'd like to point to the quote, I know you probably all have this presentation and can read it on your own. He says, because law enforcement perceives them, drug-induced homicide laws, as an effective signaling vehicle, Such counterproductive efforts receive wide media coverage. Contrast this to Good Samaritan laws, which typically receive little exposure and are only marginally known and understood by the members of the public. That piece, I just want to draw attention to, because in my work with people who use drugs, doing research across the state, that was something that came up, is that people are still very unaware of Good Samaritan laws, or they're distrusting of Good Samaritan laws because you have these competing signals and one is kind of louder than the other piece. Next slide, please. And again, referring back to that do not prosecute advance directive, this is from Katie Simon, who's a part of this large national organization called the Urban Survivors Union. And they are basically a national coalition of drug user unions from across the country. They do a ton of policy advocacy. And she states, if I die of an overdose, I demand that no one be prosecuted for my death. If you grieve for me and you seek vengeance, channel that rage to work to end the war on drugs. It is criminalization that is killing us, not fellow drug users and low-end dealers struggling just like us to survive. It is the drug warriors who condemn us to death. I will not be a symbol for them, a white woman whose life's work is forgotten, so that her death may be leveraged to continue to wage a racist, classist war on people. Because it is the white faces of drug users like me, which are often held up to justify these laws. And it is Black and brown drug users, like many drug users, who are often more convicted and sentenced. If I die, I refuse to be wielded as a weapon against other marginalized drug users in my community. And I show this to you today because this is the reality of so many folks across the country that are signing these do not prosecute advance directives. There's also a toolkit, which the link is below on this slide if you'd like to check that out on your own. And what's interesting about this is drug user unions are kind of converging with the same information that research is showing. So next slide, please. And how this intersects with the goals of SB 90 and this body, the SURG, is it affects all of these populations that were mentioned within statute and within the bylaws of the SURG. So all of these populations are potentially impacted both by Good Samaritan laws and drug-induced homicide laws. I'd also like to point out, just as I did a few slides ago, that there are populations that are disproportionately impacted, especially drawing attention to BIPOC communities, which are Black, Indigenous, and people of color. And Hispanic Nevadans have experienced a 120% increase in overdose deaths from 2019 to 2020. And this was just in a recently published article by Sean Thomas, if anyone's interested. Next slide, please. So what does the research say on this as far as best practices? Well, as I mentioned, there's still sort of minimal understanding or minimal trust of Good Samaritan protections. And so what we haven't seen a whole lot of since 2015, when Governor Sandoval signed the Good Samaritan law, SB 459, into effect, are like these mass media and public campaigns that really highlight these protections from the Good Samaritan overdose law. We've seen lots of layperson distribution of naloxone. I think we've saturated our communities pretty well, but we have not really seen any sort of media campaign that addresses this. The research also says that we could promote non-enforcement police outreach to connect individuals to treatment. We have seen this across the state. We've seen more and more diversion law enforcement teams and outreach law enforcement teams really trying to get out and be helpful and offer people resources and establish those relationships necessary to connect individuals to treatment. Also, the implementation of overdose prevention locations to facilitate incident response and provide treatment opportunities. We recently had Kaylin C come out for the Harm Reduction Summit in Las Vegas on July 19th and in Reno on July 20th. And she had a ton of data. I really hope that she can present to this body or one of our other subcommittee bodies on what that's looking like in New York. Next slide, please.
Lisa, just to let you know, you were at 21 minutes. So
Oh,
we're getting
okay.
close to the very end here, but I just want to make sure we get to those best practices.
Thank you. And this is just wrapping up. So again, I won't read all of these. They are on the slides. Hopefully they're on the website or distributed to the body. But I want to call attention to sort of what the research says. And this is from the Law Enforcement Efforts to Fight the Opioid Crisis, which is a publication published in 2019. The citation is at the end of this presentation. All of the recommendations from this multidisciplinary and law enforcement convening also matches on to what we're seeing from drug user unions. They're very similar recommendations. Next slide, please. And so just looking at some of the gaps and opportunities to improve in Nevada, there is minimal information on Good Samaritan protections, as I stated. There's also that competing message, which is probably larger or probably louder to people who are at risk and who are afraid and who are stigmatized around this drug-induced homicide policy. There's also have been some media disinformation on dermal or airborne dangers of fentanyl, which is not based on scientific evidence. Access to on-demand medication for opioid use disorder. Oftentimes this is full of a lot of barriers to access. And then trusting relationships with people who use drugs, especially in the BIPOC communities. And that wraps it up. Thank you everyone for your time and the opportunity to present.
Thank you so much, Lisa, for that information. There's a lot to unpack there. And I know there's a lot of interest in some of the themes that you touched on. Before I open it up, I just have a quick question for you. You referenced about other evidence-based practices to address overdose and deaths. On that slide, you said that in the references, there was one particular report that summarized that, that list of recommendations between law enforcement and the substance use treatment community. Can you point to which one that is, or was it a combination?
Yes, it's the Goodison article that was published. Next slide, please. There you go. Goodison, Vermeer, Barnum, Woods, Jackson, and the RAND Corporation, law enforcement efforts to fight the opioid crisis, convening police leaders, multidisciplinary partners, and researchers to identify promising practices and to inform a research agenda.
Great. So that's the fourth one down on the list of references. Would make for a good homework assignment for our subcommittee members, especially as we're tackling the balance between public health and public safety. And what particularly stood out to me was that pie chart looking at who's captured in the accused deceased dyads. That was slide number 54, and it showed that 50, it's basically 50-50. You have 50% are family, friends, and partners, and then 50% are the traditional dealers, buyers, or the patient and donors. And so I think that's our challenge, right? How do we go after the illicit dealers, and then how do we ensure that we are not capturing the family member that is caught between the two worlds of saving their partner, child, mother, grandmother, and calling and being fearful of repercussions. So very valid discussion. I know that we have members who I'm sure have questions, so I'd like to open it up if there's any specific questions for Dr. Wagner or Lisa Lee, our subject matter experts on this topic. Okay. We have Dr. Terry Kearns has her hand raised. Please go ahead.
Yeah, I just wanted to ask, it struck me about the fact that our Good Sam law is not as well advertised as we would like it to be. And I know personally, as I went around, I always ask when I was doing presentations to groups of how many are familiar with the Good Samaritan law here in our state. And usually I would get 1 or 2 hands. Typically it wasn't a lot. And I just wonder from Dr. Wagner and Lisa Lee, if they have suggestions on ways we can do a better job in getting the word out on the Good Sam law.
Thanks, Terry. This is Carla Wagner. I think there's a couple of issues. I think certainly awareness of the existing provisions is one concern, right? If people don't even know what's on the books that is designed to protect them, that is a problem. But what we know from the evidence is that most laws don't offer the kinds of protections that people are really worried about. And the concern here is that that Good Samaritan law that we have on the books is in direct conflict with the drug-induced homicide laws, right? So increasing awareness about what protections exist is one step, but also ensuring that the Good Samaritan law as written will be enforced as written, because people don't trust it and don't trust that it will be enforced. And then resolving this conflict between the protections offered by the Good Samaritan law and the risks induced by the drug-induced homicide law is the more critical tension to resolve. Because we can educate people all day about what the law in the book says, but if they don't trust that it's going to be enforced that way, and they know that there's this other provision that could subvert it, it's not going to matter. And my own research shows that, national research shows that. There's a lot of data to support the fact that people are, as Lisa said, the message from the homicide law is just so loud. And we need to be louder than that with the public health messaging.
Thank you for that question and answer. Other members, do you have questions? I know that one of the charges of this committee is that we are going to be making specific recommendations, and we do have a legislative session coming up in 2023, and we'll be taking a look at these recommendations and any specific language, because I do know that in the legislative side, there is language in good faith and how that interacts with helping us divide out that pie between the 50% that are not acting in good faith and the 50% who are. Not to oversimplify the matter, but is there specific language in regards to that law that could help to balance those two interests without eliminating one or the other? Lisa Lee.
Thank you, Lisa Lee. For the record, I would point to some resources available through the Drug Policy Alliance. They have a whole toolkit on this specific topic, and they do have legal experts. So that would be my recommendation is for a homework assignment, if you're looking for specific language around that, is to check out the resources and publications from DPA, Drug Policy Alliance.
Carla Wagner, for the record, I would add that another resource that's really helpful here is the Network for Public Health Law. They have legal analysts and legal consultants online who look across states at different provisions, and they have a lot of resources to offer here.
And could you just repeat that one more time for us, Dr. Wagner?
It's the Network for Public Health Law.
Thank you. That is helpful to our subcommittee and to our consultants as we continue to, we want to remind our subcommittee members, we do want to be putting recommendations forward that are evidence-based, and we will be asked in our final report to the extent possible for our recommendations to point to those resources to help to justify and answer questions as they may arise in the process. Any other questions before we move on to the next presentation? Lisa, you had a final comment?
Yes, just one more resource, I'm sorry, to include. There's a resource from the Health and Justice Action Lab. That's Leo Beletsky's team at Northwestern University School of Law. It's called the Drug-Induced Homicide Defense Toolkit. It's a compilation and it's regularly updated. It's on the 3rd edition, which was published in 2021. It is chock full of the latest research and resources and recommendations. And so if anybody's interested in reading that.
Okay, thank you so much. Well, we have more to cover here, so I appreciate Dr. Wagner, your time, your expertise. Thank you so much for that presentation. And any of our presenters are welcome to stay on for the entirety of this subcommittee meeting. And Lisa Lee, I'm going to pivot back to you because I do believe we now have Kate Thomas with us from Washoe County, and we will go back to what are our county responses. We heard from our own Shayla Holmes earlier about Lyon County. Now we'd like to circle back to Washoe County to hear the things that that you're working on that's working and the challenges that you still need to address and ways that we might be able to help make recommendations around those. So with that, I'd like to introduce Kate Thomas, and since we already heard Lisa Lee's background, and then I'll let the two of you take it from here.
Thank you, Assemblywoman. Can you hear me okay?
Yes, ma'am.
Great. Well, good morning, everyone. For the record, I'm Kate Thomas with Washoe County. Thank you for having us today to speak to you about some of our challenges and successes. We'll go through the next 4 slides, which is a broad overview of the services that Washoe County provides. I'll highlight for you some of the areas, if you're not familiar, of service functions that we provide and how this issue and what you're trying to achieve through this subcommittee touches our organization. I am not the subject matter expert by any sense of the imagination, but you will see in broad brushstrokes as we progress through the next slides, which we can start on slide number 2, you'll see how it impacts all areas of our services. So in blue, I've highlighted for you of the Washoe County services areas that are aligning with the mission of this subcommittee. You'll see that the district attorney obviously works in this space with prosecution of justice involved individuals. On the contrary, we've got indigent defense is a service that we provide through our public defender, alternate public defender, and conflict counsel services. And then, of course, the medical examiner as our regional and represents 14 counties in the region and several other states doing death investigations, which we've seen. On the next slide, you'll see that we have intervention, guidance, and control programs under juvenile services, which is our Jan Evans Juvenile Justice Facility. So we certainly deal with substance use there. We have the Human Service Agency, which touches all areas of assistance in the county, especially in child protective services, which Lisa will touch on in a little bit to drill down on some of that. And then our public guardian, which is a little service that not many people know about, which is where we provide guardianship for persons that are unable to manage their personal or financial affairs. So the court appoints us as guardian and making medical and financial decisions for individuals that are not able to do that on their own. We'll move through with, and these are all state mandated services, by the way. So we touch on a lot of regional facilities and programs here at Washoe County. We have 3,000 employees. Obviously, we service the entire 6,600 square mile county, including the detention facility, the Sheriff's Crime Lab. We offer a program called Crossroads, which many of you have heard about, where we do recovery for men, women, and families. We have recovery homes, and we have a dedicated rehabilitation program there. And then we took on the lead role for regional homeless services in 2021. So we are the lead role, Washoe County, whereas previously we had the City of Reno service as the emergency shelter provider for the region. We are now leading that effort. And as you can see by some of the services that we provide, it makes a lot of sense as we look globally at what the human element of service provision the county provides and how we can move through the most efficient way to help through legislation like this subcommittee is looking to achieve. You know, how do we help all of these various departments navigate certain issues of which substance use is certainly prevalent. And then finally, I think I've got one more slide. I'm a control freak, so it's weird not having control. There we go. But we've got our community services that we provide regionally. I talked a little bit about the sheriff. We have our alternative sentencing division department that does regional drug testing through the Sober 24 program. So you can get court ordered to show up at our facility and drug test randomly, drug or alcohol test randomly throughout the week, 365 days a year. And then finally, a new service that we provide, which gives us some federal funding, is the ARPA money. And what we call community reinvestment, whereby we provide community resources through the federal funds, or we bolster internal departments and try to help them achieve greater success within their department, given the money that we're getting from the Recovery Act. And we're seeing that there's a lot of nexus between, for example, homelessness and substance use, that we can dedicate resources to try to make a bigger dent in our organization as a whole. So on the next slide, you'll see what we've identified as, oh wait, there we go, our regional issues. So when we sat down and I started thinking about this, when Assemblywoman Tolles reached out to me to talk at a county level about what some of our issues are relating to this subcommittee, we are seeing a significant lack of beds or places that we can have people work on self-care, work on recovery. Right now, we've got our law enforcement teams, the hospitals, our emergency management service providers looking for they'll pick somebody up in downtown Reno and they really need a location to take somebody. A lot of times it ends up being the homeless shelter, which is not an appropriate location for folks. So really those beds is a big shortfall for us in this region. And I know Lisa can talk a little bit more about that. We have a significant nexus between our homeless population. I talked about how we've taken the lead role in that area, and we're starting to really gather a lot of data about the individual that we're serving. We see a lot of challenges with substance use, individuals using substance in our homeless population that we oversee. We have 2 campuses here. We have 604 individuals staying in the congregate shelter on the CARES campus. We have 50 individuals in our SAFE camp, and we have nearly 300 women and families at the Our Place campus. And so we're seeing a lot of challenges in that population. And then I know Lisa will do a little bit deeper of a dive on the prevalence of parental substance use, which is causing our child protective services folks to see a lot of activity there with abuse and neglect. We do removals, we have foster family placements, and it's sort of, this issue sort of threads through a lot of the services that we provide. And if we can make big impacts in certain areas, I think we'll see tremendous gains. And then lastly, we identified that for us to make strides in this area, we need the people to do the work. We are, for example, we have hired 6 mental health counselors at our CARES campus, and we're having a tough time filling those spots. So we're seeing workforce shortages that don't allow us to continue the work that we want to do in this space. And so those are the issues that we've identified as sort of our top issues for the county. I'll have Lisa do a little bit more of a deep dive as we go through our slides. She's going to talk a little bit about the substance related child home removals and such. But the next slide shows that I looked at the people that you are serving and the populations associated with the work that you're doing on this subcommittee, and they all align with the individuals that we serve here at Washoe County. And so we're really fortunate to have a Lisa Lee on our staff to jump in with lived experience and kind of take the reins when, I'm big picture thinking about how all of these programs and processes align together around the organization, where she can really make those specific recommendations that drive us towards the biggest bang for our buck as we look at potential solutions or legislative remediation. So Lisa, I'll turn it over to you. I know the next slide, you're going to go a little bit deeper on substance related child home removals. And then, of course, we'll loop back to me and Lisa with questions at the end, but I'll turn it over to her.
Great. Thank you, Kate. And thank you, everyone, for the opportunity to present again. Hopefully you're not sick of me after this. So looking at, this is my passion area. It has been for a long time, working with parents, specifically with an opioid use disorder. So I'm thrilled to be able to continue this work at a much larger level within the county. And we are seeing a lot of child removals, and that means they are in out-of-home situations, either with kinship placements or with foster families. We're seeing that intersect with parental substance use a lot, and we're seeing that increase over time. So you can see here the data could be improved. Our data collection could really be improved in this area, and I think we're all working towards that. I know that we're all being trained on a new data system that will help us to create enhanced reporting on our end, on the data quality end. And so you can see here parental drug use and parental alcohol use, parental methamphetamine use, and then infants that are affected by prenatal drug exposure, or what I refer to as IPSE.
They still make them?
I'm sorry. I think someone's not muted. If you could kindly check your mute button, thank you. So we are seeing that increase. Next slide, please. And you can see that trend line there over time. These are, again, referrals, so not removals, referrals into our system. Typically hospitals, per our CARA law here in Nevada, hospital social workers are initiating those referrals to our system, to Child Protective Services, around infants that have been prenatally exposed to substances. We are seeing that increase over time, as you might expect, especially during 2020, which was really a year that saw a lot of people have recurrence of use. So a lot of people in recovery return to use. There was an uptick in alcohol and substance use. And of course, mental health issues were exacerbated by these larger things that were happening. Next slide, please. And so just to get a little bit granular into the details here, again, our reporting it could be improved, I'll say that, but I did go through and look at every single referral that came into our system and read through those reports to get this data, because the check boxes are they're really broad, and I wanted that granular detail to see what trends we were seeing in our system. And so unfortunately that took really like reading over 900 reports and putting it on spreadsheets and doing some calculations here. So in 2020, right, during the pandemic, we saw a lot of THC exposure, cannabis exposure, which we still see as a trend. The second highest was for polysubstance use. And you can see on this table here, kind of what substances were included in that polysubstance use. So alcohol in combination with other substances, etc. We also saw methamphetamine comprising 16.7 of those exposures. So we know that that's still pretty much a dominant drug here in Washoe County. We also saw a few trends that were pretty alarming. We saw parents that were unstably housed. We saw quite a few parents that were being referred for their infant who was prenatally exposed, who also had their own cases as children. So we're seeing that intergenerational cycle continue in our system. Lack of prenatal care. Often pregnant and birthing persons were citing COVID-19 as a barrier to accessing prenatal care. Severity of medical fragility in a lot of those babies. And we did see a lot of babies that were born outside of a hospital setting. So we saw babies that were being born in sheds, on a sidewalk, motels, in a toilet. I'm trying to think of all the things that I saw in those reports. Apartments, a lot of different outside of a hospital. Next slide, please. So in 2021, we see that trend continue for prenatal cannabis exposure, really sort of dominating what infants are being prenatally exposed to. The second highest, again, is that polysubstance use. And again, methamphetamine, this time comprising 49.1% of that polysubstance exposure. So again, methamphetamine is really dominating that illicit substance use among pregnant and birthing persons. Again, some of the trends we saw were that unstable housing. I think this is definitely on the rise across the country, including in our region. We just don't have adequate housing. We're seeing a lot of co-occurring disorders as well. Trauma, CPS cases as children, again, babies born at home, minimal prenatal care, lack of transportation, and that housing piece. And of note, 2 of the infants that were reported under CARA were born to mothers in recovery. One mom had 10 years. So I find this particularly alarming because obviously that infant was not affected by prenatal exposure, yet these calls are coming into us. So this is a question broadly around when does that end? When does that CARA report? What's the threshold as far as the pregnant or birthing person's time in recovery? Next slide, please.
Lisa, just to let you know, we're at 15 minutes.
Okay, perfect. I'm going to breeze through this. So what's working well? Well, we are working on that opioid needs assessment. I am leading that. We've had a lot of stakeholders involved. I am not using community-based participatory research, rather community-based participatory practice, which is, that seems to be relevant for a governmental agency to conduct. We have people who use drugs at the table who have been really key stakeholders in helping to develop the interview guides, surveys, et cetera. So really kind of guiding that work. And then I am just buried in data. So thank you to anyone on this call who has provided their data to include in that report. It is great to see so many different pockets of our population included together, because you can really start to see sort of the trends in the justice involved population and certain treatment providers, et cetera. So I'm really excited to be leading this in conjunction with community members who have really shown up and been really, really helpful. And then we do have naloxone distributed at the shelters, but that's Our Place and Nevada Cares. I just did some trainings with the VOA last Friday, actually, training up their staff, and I've been continuing that work. It's been, I've been training them for several years. Human Services Agency is now a distribution site, and we are conducting those overdose prevention, recognition, and reversal trainings, as well as distributing naloxone. We also have the Substance Abuse Task Force, which was formed in 2019, really as we started seeing providers that were involved in some legal stuff, and it was sort of in response to those ramifications, what we might see in the community following those busts. That is still going on. It's really awesome to have all those stakeholders gathered and share information and data. And then there's also mental health counselor staff at CARES campus and on site at Our Place. Next slide, please. So I really want to promote collaboration here. You see the picture on the right, which is a picture of our Crossroads residents in a Facebook post with our partners Soulful Seeds, who have a beautiful community garden on that old Northern Nevada Adult Mental Health Services campus, which also houses our women's and our women and children's Crossroad programs, as well as our Place women's and family shelters. And so to see that that collaboration where our folks are able to really, work with other organizations and have some skin in the game, doing really positive things for our community is awesome to see. So that's going really, really well. And we could not do that without our community partners. Our Women in Family Crossroads programs on that campus offers tons of wraparound services. These are recovery residences. Again, women and women and children's on that campus. They also do volunteering, as you see here. There's parenting classes. There's an aftercare program, which takes place at Sober 24. And there's the Reno Recovery Alumni Group that does a lot of work within our community. Also, Our Place, which is guided by Human Services Agency. These are all Human Services Agency programs. It's a very trauma-informed campus. We have wraparound services. The staff who so on the Reno Initiative for Shelter and Equality, who's our vendor, are mostly people with lived experience, which is really, really awesome to have. And then we do have on-site clinical services and an early childhood education program on site. And that is available for residents of Our Place, as well as residents of the Women and Family Crossroads, as well as staff. So that's really, really awesome. I cry when I go to that campus. Next slide, please.
So I'll jump in. I think, Lisa, we
Okay.
have a field trip.
We are going. Field trip.
We should have an extracurricular field trip. I'm
Okay.
going to move through these slides pretty
Yep.
quick.
Please go through these pictures. Yep.
Some great pictures. I encourage our members to take a look. Definitely got to hear some of the best practices. It appears here we've got the Safe Babies Courts as an option, which goes back to that question that I had about, what do we do about our children being impacted in, prenatal, in the prenatal phase, and as well as in the Child Protective Services and Clinical Services team, and then home visiting programs, sobriety treatment, recovery team, and the START model. And so is there anything that you just want to highlight on those two slides, or can we move to the gaps and then let our members get to the references on their own?
If we could move to the next slide, I'll quickly just talk about this pilot that we're starting now. We're implementing and leading the implementation of this, the sobriety treatment and recovery team model, which incorporates peer recovery support specialists and partners them with a caseworker to work with families where substance use is a factor of child neglect or maltreatment. Next slide, please. So some of the gaps that we're seeing, again, as Kate Thomas pointed out, availability of treatment beds is a huge issue in our community. Again, also adequate infirmary and treatment program expansion at the detention facility. As we know, our jails have sort of become ad hoc mental health, like behavioral health treatment programs. And so expansion is necessary. Again, that behavioral health workforce shortage is an issue that we are currently dealing with. Crisis stabilization programs. We are working on this. As you know, implementation of 988 is in full effect since July 16th. We need to build the infrastructure to be able to support individuals who are in crisis. There's also a lack of family-centered treatment centers. And what I mean by that are places that serve couples and children. We have zero. We have nothing in recovery residences or treatment programs that really look at that family-centered approach. Affordable housing, huge issue across all of our systems. Childcare availability, we vouchers, but nowhere to place children. And then foster homes, we see a decrease in this, in foster homes, and then an increase in children entering that out-of-home care placement setting. And that is it. And we are open to take questions. I appreciate your time today.
Thank you so much, Lisa and Kate. Do we have any questions while we have these two subject matter experts on the line from members? Crystal, if you could pull it to the full screen, that way I can see if anyone has their hands raised.
I don't see any hands raised from
Okay.
members.
Thank you so much, everyone.
I don't see anyone either. Thank you so much for your time, Kate, and for your expertise, Lisa, as well. I know some of these I definitely want to dig deeper into because they do fall in line with our response subcommittee, and they are not ones that I see on our current list of recommendations. And then we also are going to obviously cross-reference those with prevention and recovery and treatment that I know do touch on some of these categories. But you brought up some critical gaps here. The housing is a theme that we've heard time and time again. So I imagine that we will be putting that into our recommendations for now and for the research, but definitely want to make sure that we're addressing those special populations, particularly our children and prenatal care. So thank you so much. We have 2 more presentations. My intention is to go through those 2 key presentations we have on our tribal needs, as well as our overdose fatality review pilot. Give us a short, after we're done with those presentations, a short bio break just to grab a glass of water or take a little break if you need it for about 3 minutes because we're getting tight on time. And then we'll come back and we'll dive into our recommendations. So with that, I'd like to pivot over to the presentation on state opioid response tribal needs assessment. We have Michelle Berry, Morgan Green, and Karina River from CASAT at the University of Nevada, Reno, an excellent program. And great to see your familiar faces again. I'll start with you, Michelle, and if you'd like to introduce the rest of the team and dive into our presentation, and I'll let you know when we hit the 15-minute mark. Just
Sure, thank you. I'm Michelle Berry. I'm a senior project manager at CASAT at the University of Nevada, Reno. The State Opioid Response Grant is a collaborative effort between the State of Nevada Division of Public and Behavioral Health and CASAT. And so we help to administer the funds from the State Opioid Response Grant. With me today are Morgan Green, my project coordinator, and Karina Rivera, our SOAR evaluator. And so one of the major pieces that was needed for the completion of our SOAR grant last year was to facilitate a Nevada opioid response tribal needs assessment. And so this was done during the time when we were all locked away with COVID. And so a lot of it was done third party, but I'll turn this over to Karina to begin the presentation.
Next slide. So just to look at the history of what we did with the needs assessment. So we knew from as soon as the FOA was released that we were going to need to do it, but I started a little bit before just in showing that we were already looking at what the needs of the tribes were with our prior funding cycle and responding to those needs by providing overdose education, naloxone distribution, and MAT trainings. But so we found out in spring 2020 that we were going to need to do a needs assessment. So this is the height of the pandemic, April 2020, but we started reaching out to our partners at the state, the tribal liaisons, to see if one already existed so that we could start based off that. We found out that one did not. And so then we moved from there to do a literature review and see kind of what other states are doing, what are other jurisdictions doing. We also then reached out to find other partners who might have better connections than we did. Meeting with Project Echo, who said that they were going to be doing one. Then we reached out to school public health faculty who already had experience in working with tribal communities extensively. Unfortunately, since she was new to Nevada, she did not have the connections within our tribal communities. Then we reached out to the Council of State and Tribal Epidemiologists who had met at a state meeting back in 2019, thinking that she would be able to provide guidance based on their past assessments they had done. And really, she said with the ongoing COVID-19 pandemic, they had competing priorities, and she didn't think this would be a good time for us to do any primary data collection with tribal communities. So then we went back and decided maybe we would just stick with secondary data collection for now. And so we made a couple of different data requests from the state. And Next slide. So like I mentioned, we did a literature review, found there was a couple opioid specific tribal needs assessments that were already out there, some that were broader of substance use, and then some that were even broader of just health needs assessment in tribal communities. Next slide. So then we looked at what were the indicators that numerous needs assessments were looking at here, or ones that we knew that the state had, or we thought the state had. And so this is what we wanted to look at when we went into then putting in those data requests. Next slide. So here we are just looking at, so overall in the state of Nevada, 1.1% of the population is American Indian or Alaska Native. And here you can see in the gray that it was about over every year, it's about 1.1%. Of the opioid use disorder diagnoses are individuals who are AIAN. But you'll see in the yellow line, that is the percent of those who are treated for an opioid use disorder. And then in the navy blue, it's specifically those on medication assisted treatment. So it is less than the proportion. Next slide. Here, we also looked at, this is a map of all of the tribal health centers in the state of Nevada. And what you can, unfortunately though, out of all of these, is only 4 of them have any providers who are waivered to prescribe buprenorphine. So 4 of the 14, and 2 of those happen to be tribal opioid response grantees. We also looked at access to AA meetings, NA meetings, and what we found on all the online lists of them is that there are currently none that target the American Indian Alaska Native community. But there are a few in the less urban communities near tribal areas. But due to the COVID-19 pandemic, many venues closed, and so they moved their meetings online, which may not be great for the rural communities who have less access to good internet. Next slide. So here is a look at opioid poisoning inpatient admissions. The navy blue is American Indian Alaska Natives. Since this so few, all of these slides are going to be aggregating multiple years, since there is the percent or the rates are not reliable, because it's just like 1 or 2 people would change the rate dramatically. So we looked at pre-funding for STR/SOR, so opioid funding, to post funding or during funding, to make those numbers more stable. So 3rd highest you'll see is American Indian Alaska Native. But there was a small decrease over the time period. Next. Emergency department encounters, again, 3rd highest. There was a larger decrease, and then they were 2nd highest. Next. Actual death rates, still Navy. So 2nd highest is a very small decrease than that you see in pre to during the funding. So since we were not able to do any primary data collection at the time, we are still interested as we've moved a little bit further in the pandemic. Looking to potentially work with the tribal consultation meetings to gain feedback on what they would also find useful to learn about, so we can do this more collaboratively and get more buy-in. Morgan or Michelle, would you like to add more?
And we'd also like to welcome feedback from stakeholder groups and statewide groups for information to be considered and incorporated as a more in-depth primary data collection assessment is developed.
And we really don't want to make anything actionable until we truly have the backing of the tribal organizations themselves. We want to make sure that this is truly representing their values and what they feel comfortable with in implementing within their own organizations.
So this concludes our presentation.
So you made it quick.
Thank you so much. Well done. Do we have, this is important. I appreciate even if it's just, here's the progress of where we've been, where we are now, and where we need to go. One of the categories in our report that we anticipate will be publishing in January will include a for further research. And to your point, being able to make sure that we have thoroughly vetted recommendations as well as a truly robust stakeholder inclusionary process is going to be key to those recommendations. And so I appreciate the report of where we are today and where we still need to go. Members, do you have questions for our presenters? I do see a hand raised. Dr. Terry Kearns, please.
Hi, thank you guys for the presentation. I appreciate it. My question revolved around the facilities. You said there were 14 healthcare facilities and only 4 of those are offering buprenorphine or waivered, have people who are waivered to give buprenorphine. Are those providers using their data waiver and providing these services, or are we still seeing our tribal populations happen to go outside of those facilities for that type of treatment? Thank you.
I don't think we fully know that. I think everywhere we have surveyed providers to see if they are prescribing to their capacity. They have not been. We did look at Medicaid billing and it was not getting billed there. But I know that we would not have access to all billing for IHS.
We also want to point out that we knew that these 4 facilities had prescribers at the time that this assessment was done. A lot of the tribal organizations do have a high turnover in terms of what's going on. So I know one of the locations themselves had actually dropped all of their harm reduction and MOUD components once COVID hit. So I don't know how many of them are actively truly prescribing or providing services around OUD and medication assisted treatment.
Thank you for that question answer. Any other members with questions? No, I just want to go back to the slide, and I don't have the copy in front of me, but there was a slide after the introduction of, let's see if we could, Crystal, if we could screen share that again. And go back to there one next. Okay, if we go back to the opioid poisoning inpatient admissions, just what really struck me here is the discrepancy between various populations and where we saw a reduction in some categories and an increased amount in others. And on that next slide as well, for emergency department encounters, again, where certain populations are receiving some of these treatments and others aren't. And that's certainly a task of this committee as a whole, is to be able to make sure that we reduce any discrepancies between populations and identify what those underlying causes are. So just wanted to point out that that caught my attention in your presentation. I appreciate your continued work on that. Dr. Kearns has her hand raised again.
I'm sorry, you pointing that up spurred another question for me. I just wondered, I know there's been talk about implementation of bridge programs in emergency departments to start individuals who need it on medication assisted treatments. Is that something that's being looked at in our facilities that cover our tribal communities? Do you know?
So it's being looked at across the state for the implementation of programs for the induction in emergency departments, but it's also dependent on if there is a provider located at that emergency department that has a waiver. And if there is interest, if there's a team, access to a pharmacy that can provide the medication on site. So there's a little bit of a checklist that needs to be gone over, but once that project starts rolling out, it's open to any hospital that wants to participate.
Okay, thank you so much. I don't see any other questions and appreciate your time. Hope we get a chance to see you again, and that the whole team gets to continue to work together on this, making sure that we really press forward on that stakeholder engagement and recommendations. So thank
Great.
you for all your work in this area.
Thanks for having us today.
Yes, thank you. All right, we're going to go ahead and move on to Elise Monroy and for a presentation on overdose fatality review pilot. This is our last of our presentation section today. Elise, thanks so much for being patient, and it's good to see you.
It's really good to see you. I'm holding up the presentation team today. Here we go. Let's go. All right, everybody. This is a pretty familiar group. I recognize a lot of the names here. If you don't recognize me, I hope we get a chance to meet soon. My name is Elise Monroy. I'm the program manager over the state's overdose data to action program. And I'm here today to talk about a pilot project that our team undertook to pilot an overdose fatality review. Next slide. So I've got my funding disclosure here. I am, so OD2A, like the SOR grant, is a collaborative program between the UNR School of Public Health and the Division of Public and Behavioral Health OFI office. I'm full-time administrative faculty at UNR, and I work really closely with the folks at DPBH to support our grant functions. Next slide. OD2A is the state's main source of CDC funding for fatal and non-fatal overdose surveillance. OD2A is a pretty expansive program. In addition to supporting the state's fatal and non-fatal reporting, we support the PDMP, EMS data collection, and a system called OpenBeds. We're working to improve the quantity and the quality of overdose surveillance data that is collected and reported throughout the state. And I would just like to validate something that Shayla brought up in the beginning around the lack of standardization for data collection. That's something that we are very familiar with the OD2A program. And if that's something that you guys as a committee would like to dig deeper into, we have a lot of resources I think we can share. So we currently report out, we do monthly overdose surveillance reports. I'll put the sign up link. So if you guys don't get those, we can get those into your inbox once a month. And then we do it says biannual fatality review. I clearly had fatality review on the brain when I was doing this, but we do biannual fatality reporting. Next slide. So I'm not going to go into data. There's actually been a lot of our OD2A fatality data has been spoken to already today. We all know that overdoses continue to rise, but what I would like to kind of point your attention to on this slide would be this right here, the circumstances that were documented. This tells us about, this kind of gives us information on a kind of more qualitative level about people that are dying by fatal or by unintentional drug overdose, but the information is really limited. Next slide. So before we get into our pilot of the fatality review, I think it's important for everybody to know kind of how we currently get our fatality data. So Nevada collects fatality data generally in two ways. First, the OD2A program supports the state unintentional drug overdose reporting system, or SURG. We have a partnership with the coroner medical examiners and data abstractors who collect this data. It's reported on twice a year. We split the year up. So we just reported out on January to June of 2021, and pretty soon in the next couple months, we'll have the second half of data. The SURG data tells us we get demographic data on overdose deaths, and we also get a breakdown of the top substances listed as the cause of death. So that would be how the state is knowing what people are dying by through that confirmatory tox assessment that's done by the coroner. And then we also get the circumstances preceding death, which is what I just mentioned. Next, the state also pulls fatality data from the Nevada Electronic Death Registry System. This is also known as vital records or death certificates. This data is pulled monthly and annually. We get demographic information, and then we get, this is suspected overdose information, and sometimes a suspected substance is listed. Okay, next slide. So some of the limitations that we have with our fatality data, timely fatality data is not confirmatory. So we can get the death certificate data that tells us about suspected overdoses that are happening, but we don't know if those overdoses are by fentanyl or are polysubstance. We can just get a suspected cause of death on there. The next limitation is that our confirmatory data is not timely. We get our substance data, our cause of death data from the SURG system, and that's reported out twice a year. So by the time we kind of get around to reporting out our SURG data in alignment with CDC protocols, the drug landscape will have inevitably changed. And then also we have limited insight into decedents' interactions with systems that we all work within and are working to improve. We get, again, the circumstances prior to death, but that tells us very little about decedents' background, you know, if they have complex health issues, if they have been, you know, in and out of jails, what their school education might look like. So those are some significant gaps. So next slide. So I have an example of how the data limitations kind of impacts our ability to meet needs in the community in a meaningful way. So it was mentioned before a couple times that in 2020, Nevada's Hispanic community saw a 120% increase in fatal overdose deaths, but a 227% increase in fatal overdose deaths. So when we started, I guess, socializing this data, we got met with two questions pretty significantly. And those were, oh my God, what is happening? What is happening that this community is being so impacted? And we were able to break out the SURG data and look at the circumstances prior to death and the toxicology information, but that was very little to go on. So we really didn't have much to say other than, you know, there was the rapid discontinuation of legal prescriptions, which could have pushed people to the black market where there's fentanyl, but really we had very little to go on. Next slide. So here is where we get to an overdose fatality review. So the goal of overdose fatality review is to identify system gaps and innovative community-specific overdose prevention and intervention strategies. So I felt like, and I'll just say, I probably should have led with this, very little of this presentation today is going to be our findings from the OFR, and I'll explain that. But I think it's more important for this committee to be thinking through how the state should develop an overdose fatality review. So we'll talk at a really high level about what our findings are, but we really wanted to focus on the process. So in order to focus on the process, I think it's important to look at Nevada's existing fatality review. One of the barriers, I guess, or the challenges that has come up is that overdose fatality review would need to be enabled in statute. So, and that is, I mean, there's no law that needs to be enabled that would allow multidisciplinary teams to come together, but you really need to have enabling legislation to share documents across agencies and systems. So we were able to identify 4 fatality reviews that exist in state statute today. And I thought I had the NRSs on there. We'll include that in the final report. But there are 4 existing fatality reviews. And then I also wanted to bring up kind of some of the intersections that these fatality reviews have in either the target population or the issues they're dealing with overdose. So first, Nevada has a child death fatality review. There are 6 child death fatality review teams in Nevada, and then an executive committee that is run by DCFS. In 2020, opioid issues came out as an issue area of concern for a local overdose response team. And we know that there are many shared risk factors with child fatality and trauma that impact overdose and substance misuse. Next is a domestic violence fatality review committee. This is housed in the Attorney General's office and is intended to look at victims that have died by intimate partner or domestic violence. We found an interesting study that found that opioid use is elevated in intimate partner violence, or IPV, as compared to the general population. I also know that Kat from Southern Nevada Health District has done some really interesting work on this issue specifically. Next, we have the maternal death review. I think this committee has been meeting for some time, but was recently enabled in legislation, and they look at women who died kind of, I believe, in that first year of childbearing, and it lives within the Division of Public and Behavioral Health. When we look at the most recent maternal death report, we see that 80% of drug overdose deaths had non-transport accidents as an underlying cause of death. Additionally, this report found that 100% of drug overdose deaths were unintentional. And then finally, Nevada has a suicide fatality review. There's kind of a growing body of work that really shows the intersection of suicide and unintentional or intentional opioid overdose. Next slide. So given some of that, the information that we looked at around the intersection of opioid overdose and suicide fatality review, we reached out to the Office of Suicide Prevention to see if they would be willing to pilot an overdose fatality review with our program. And the Office of Suicide Prevention was more than willing to do that. So we presented the OD2A program at a couple suicide fatality review committee meetings to garner committee support for that. But the coroner medical examiner committee members actually had a lot of concerns about being able to determine intent of death, where we have intentional versus unintentional overdoses. I think we spent 2 meetings talking about that challenge. So what the committee decided was to establish a case definition that would look at overdoses of undetermined opioid or overdose poisoning. I also thought that was an interesting choice for a case definition, because understanding why those cases were undetermined could give us, as a state, kind of some interesting insights as to data points that might be missing or data points that might be helpful. For the pilot, the committee looked at 4 cases. It was a mix of urban and rural, and the overdose fatality review happened in June. It was a hybrid meeting, and it happened as the second day of the suicide fatality review. Okay, perfect. Our missed opportunities, which I'm not going to go into because I don't know that there's anything here that hasn't been mentioned today or that folks on this committee won't be familiar with, but these were some of the missed opportunities that came out. Lack of safety planning, coordination of care, Narcan, co-prescribing, and then connection to school-based resources. Okay, next slide. These were some of the, I think we went backwards. Can we go one more? One more forward? There we go. Okay, perfect. Thank you. Sorry about that. So these were some of the findings of the committee. Again, I'm not going to go into these, and information about these will be provided in depth in the report once we get that finalized with the Office of Suicide Prevention. I really want to talk to you guys today about process and what developing an OFR would look like. Next slide. Okay, so some of our lessons learned. Okay, so for an overdose fatality review, facilitation, dedicated facilitation for the meeting has actually been called the secret sauce by the COSAP resources that provided technical assistance to us and others, noting that good facilitation helps to pull information out of participants and helps to kind of connect dots across systems. Next would be dedicated resources to support the administrative functions of OFR. And these two things kind of go together. It's my kind of assessment of a fatality review that touch behavioral health topics at this point is that fatality review is kind of a responsibility for an agency as in other duties as assigned. The Office of Suicide Prevention does have resources to support a suicide fatality review, but they're very limited. I can't speak to the resources that are dedicated to maternal and child health, but it kind of seems that like the fatality review is just something that the office is doing. So it tends to be this thing where it's competing for resources and competing for time. So having resources that are dedicated to the documentation and the information gathering can help improve the quality and the timeliness with which information from fatality review is reported, but it can also help to improve the information that the committee has to review. For our fatality review, we had actually determined our case definition in the winter with months in between. And again, kind of other duties as assigned. Fatality review is just something the Office of Suicide Prevention had to support along with all these other things. So they weren't able to dedicate administrative time that was needed to get documentation for the review. So the committee actually had very limited information to go off of. So while statutory language changes can help to enable or even mandate documentation sharing, that also requires follow-up from a person to just be on top of agencies and those key contacts to make sure documents are getting to the committee. Okay, so finally, my last slide is the OD2A recommendation. The OD2A program recommends that Nevada should support an overdose fatality review to improve the state's ability to use data to inform overdose prevention. But specifically, the overdose fatality review or the OD2A program, all these O's in my life, the OD2A program is recommending that an overdose fatality review be developed while leveraging existing fatality reviews, especially since we were able to point to so many intersections of target populations and comorbidities. I think it makes sense to leverage existing reviews, and then also to support dedicated fatality review resources, not just for OFR, probably across the board, but looking at kind of, again, how fatality review, at least in the behavioral health space, is kind of like other duties as assigned for these really tapped state agencies. It doesn't really make sense to, I think, and this is an editorialization, to put another fatality review just on top of that. One idea that we talked about, Misty and I thought it might be interesting to see what it would look like to pull members from each of the existing fatality reviews together to look at cases that impact child death, domestic violence, maternal and child health, and suicide that all have ties to overdose. So I think there's actually a lot of options that the committee has to move forward here. And there's also a lot of different structures in other states for what OFR looks like. So the possibilities are kind of endless, but I definitely think that leveraging existing fatality review would be in the best interest of existing state resources and the issue at hand. And that concludes, I believe, my presentation. My references are there and my contact information. Are there any questions?
Thank you so much, Elise. Members, do we have any questions for Elise? Dr. Terry Kearns, thank you.
Sorry, I feel like I have all these questions I keep hitting everyone with. So in your recommendation, Elise, are you saying that the overdose fatality review be like a subset or one of the fatality reviews of the existing, or those existing fatality reviews have theirs and this is one that everybody comes together separately?
I think it could be either. I just don't know. And I know that there's a lot of resources by way of grant dollars and settlement dollars to support the administrative functions of these things. It just seems like there is a lot of cross concern in a lot of these issues. And I think that by looking at overdose as more of a comorbidity to maternal child death or suicide or intimate partner violence can actually help to integrate conversations about behavioral health into all of these other areas of concern. So I think it's up to the committee, and I can help with bringing in technical assistance with COSAP or with ICF or whoever to help kind of fine tune what it would look like. I just think it would be a missed opportunity to not take advantage of existing state resources as a way to integrate how we look at overdose by way of risk factors and prevention strategies.
Okay, thank you. And Dr. Woodard, I also see has her hand raised.
Thank you, Chair. Stephanie Woodard for the record. So Elise, I'm just curious, as you were pulling this together and you had done the sort of pilot for the overdose fatality review, do you see any populations that may get missed if we try to just leverage existing overdose fatality review committees without having some expressed requirement to also focus on overdoses in general?
Well, I think possibly the Hispanic community, right? Like, I think that's a really good example of a community that is being disproportionately impacted, but maybe wouldn't fit underneath any of the existing committees. So unless we look at kind of the women of childbearing age or youth specifically, but I believe with the Hispanic community, it's kind of that 18 to 35 male that's being impacted. So I think that would be a demographic group, and maybe the BIPOC community, those communities of colors that are being disproportionately impacted but might not fit under an existing review. That being said, you know, the overdose fate, and I'm not a lawyer, but I'm going to pretend to be one. The suicide fatality review and their staff believe that overdose would be in the purview of the suicide fatality review committee. So if overdoses were going to be looked at as part of what the suicide fatality review committee looks at, the committee can determine like what populations they want to look at if there's communities of concern. Actually, during the meeting, committee members wanted to look specifically at youth, but again, we got into that concern of determining intent, whether it's intentional or unintentional. And then we had a long conversation about passive intent. So I think that communities of concern could be captured but still leveraging like the infrastructure for an existing fatality review.
Okay, thank you. And I don't see any other hands raised. Thank you, Ms. Monroy, for your work on this. Thanks for being available and hanging in there for our last presentation. And I commend you for your collaborative approach to trying to break down those silos, take advantage of existing avenues to improve that data collection and review process. That's something that you heard was a theme today as we talked about some of the other presentations. So this is your chance if you need a quick bio break of about 2 minutes while I say goodbye and thank you to our presenters. And before we move into the final segment of our work here today. And so go ahead and take some time for the rest of you who are still on the line. Thank you so much for your presentations. And I do invite you to stay engaged in the process as we come up with our preliminary recommendations. We will be presenting these in October. I believe is the plan to our SURG committee as a whole. They will refine them even further as we hear from all the different subcommittees who will be presenting, and then work on the report in November and December and have that available for publication and use in January, just in time for the next legislative cycle. So we'll just give everyone another minute to take a stretch, get a glass of water, and then we'll finish up. Okay, hopefully everyone is back. Let me see if I can get my full screen up here for a moment. We have still some members of the public, some stakeholders, and some of our presenters have stayed with us. So we welcome you to continue to watch this process. We will have time for public comment at the end. So this next section is for participation of our members of the subcommittee only. If you do have, after hearing our discussion, some thoughts to share, please save those for public comment. We will have one more time for that at the very end. But I'd like to move on to our next agenda item, which is to review the process for prioritizing recommendations and upcoming meetings. I briefly gave that summary. Crystal, if you want to bring that slide back up, I briefly gave that summary as I was releasing everyone for a quick 2-minute break. But I wanted to make a few notes, and okay. Let's see here. Crystal, can you share your screen and bring that slide back up? Okay, great. And so, so we already touched on this, but essentially we've heard from subject matter experts for months now to help inform us to have evidence-based best practices built into our recommendations. That's one of the stipulations in statute as a result of this legislation to form this committee. And now we're going to spend some time reviewing some new recommendations that have come in since our last subcommittee meeting, and then review and discuss the priority recommendations that we already had a chance to prioritize in a poll in between our last meeting and this one. And so the goal is to do an overview to get a chance for each of the members, each of you who've made recommendations, to spend 1 to 2 minutes briefly explaining your recommendation and then give the rest of the members any chances to ask questions or express any concerns. One of the things that we are looking for is the ability to consolidate some of these recommendations. You'll see that there's some overlap and maybe a little bit of repetition, some opportunities to eliminate or to consolidate. Our goal by the end of this process is to come up with 5 to 10 recommendations from our subcommittee, response subcommittee, to present to the search committee as a whole. The other subcommittees also are doing the same, so that our final report is manageable at hopefully somewhere around 15 to 25 total recommendations, with another section for further review. And on that note, I'd like to just make a few notes on some of the conversation that we've had between the subcommittee chairs in between the last meeting and this meeting. There's been some questions about harm reduction, and we heard some of those types of policies and discussion in our presentations today. And there was discussion about it resides currently in the prevention subcommittee. And there was a question raised about whether or not they could tackle that large of a topic while also addressing some of the primary and secondary prevention concerns in that subcommittee. There was a suggestion that perhaps we move it to our committee, and in a convening of the subcommittee chairs in discussion about the nature of harm reduction is really being most appropriately slotted into tertiary prevention. We decided that we're going to keep harm reduction in that prevention subcommittee, but we also recognize that that topic is a rather large topic and one that merits a lot of discussion from a variety of stakeholders and perspectives on that topic. So we are going to likely in the SURG committee as a whole discuss whether or not that is a category that we want to place into the for further review in our report, knowing that we are coming to the decision-making stage on which recommendations we feel that we have thoroughly vetted by the time this year is over and the report is due, with the subject matter expertise that we've had present so far. And so there may be some harm reduction specific strategies. One that might be categorized as that is the distribution of naloxone. We heard that in just about every presentation today in particular, but we've heard that also in our subcommittee in the past. If that's something that we receive consensus on, that we are ready to move forward with a specific recommendation around naloxone, even though it might be considered under the umbrella of harm reduction, that is something that we can vote on and include in our recommendations out of this subcommittee, and may see some similar ones out of the other subcommittees and then include in our final report. But just wanted to give you a little bit of background about that topic, because it is a rather large one and one that deserves a lot of deep vetting. Another note that I want to make about open meeting law is that we want to make sure that members are not discussing and communicating the actual priorities or thoughts about the recommendations outside of our public meeting. I mentioned that the subcommittee chairs had a meeting a few weeks ago. That was not to discuss the actual merit of each recommendation, rather to discuss how the process by which we wanted to be able to pursue how best to approach each of these categories of recommendations. So that meeting is permissible under open meeting law, but the discussion of the actual recommendations and lobbying essentially other members to align with a recommendation is outside of the open meeting law. And so I want to make sure that I remind everyone, because it is important this process is transparent, and we have really made great efforts to include the community in it. And then recommendations and priorities need to be shared with the members in the public and vetted in these public meetings. We talked about the process and the timeline. So I'm ready to move on to the next slide and the next category, unless anyone has any questions about the process, about open meeting law, or about any of those specific subtopics? Okay, I don't see any hands raised, so I'll move on to agenda item number 9, which is to review the subcommittee recommendations and preliminary prioritization. So as you know, we had recommendations already in previous subcommittee meetings. We did ask via a polling mechanism for members to just prioritize their top recommendations for the sake of discussion, so that we know what to focus our time on both today and in our September subcommittee meeting. And then we had some new recommendations that we have not yet seen or discussed at all as a subcommittee. So with that, I'd like to go through the next 2 slides, I believe, on our new recommendations that have just come in, just to do a brief overview of what those recommendations are. And then we will come back to these and discuss them more thoroughly in September. But with that, if I could ask that we'll go ahead and do it by recommender. So at first we have Dr. Terry Kearns, who has a new recommendation included in today's presentation. Feel free to just read it off, and if you want to give us a couple sentences to explain if needed. If not, we can just go with what you have written.
Sure. My recommendation was that we needed to resolve the conflict between the Good Samaritan Drug Overdose Act and the drug-induced homicide law. As you've heard from the presentation, we really need to look at, in my opinion, the balance of ensuring that we're getting individuals to call for assistance for those who have suffered an overdose, but also looking at the law enforcement side, and when they're facing a family and how do you tell someone that just lost a loved one that there's no one that's going to be responsible for that? So I think it's really going to be contingent on looking at good language to resolve that conflict between those 2 laws. They both have great merits, but I guess what's the balancing point between the 2?
Okay, great. Thank you, Dr. Kearns. And we do have a little bit of homework for the subcommittee members to take a look at some of those reports. And even though this committee doesn't have to come up with the specific language, being familiar with perhaps the different models of language so that we might be able to steer it in a direction that everyone can feel comfortable about, because as we know, oftentimes the devil is in the details. Also, members, just to help facilitate this process, if you could turn your camera on if you are able to, and then if you are not a participating member in the discussion, if you could turn yours off, that will help just us to see the members on video as we have more of a discussion about this. Appreciate that. And then I can just a reminder, you can set your video settings to hide any non-video participants, so that way we can prioritize which faces we're looking at during the discussion portion, and then we'll again open it back up at public comment. So Dr. Stephanie Woodard had a number of recommendations that were new to consider. So if you could just briefly read through those and point out anything in particular that may not be self-evident on the slides. Thank you.
Sure. Stephanie Woodard for the record. So the first recommendation is to establish a pre-arrest deflection program that enables law enforcement officers to work with community providers to divert eligible individuals away from the criminal justice system and into community-based behavioral health interventions and social services when appropriate. The goal here is to differentiate the difference between deflection and diversion. Typically, diversion occurs once an individual has come into contact with a law enforcement officer, primarily because some crime has been committed, where diversion is prior to any crime being committed. And so really trying to establish programs and authorities for law enforcement agencies to really engage in not only diversion, but deflection programs. The second is to modernize Nevada's civil protective custody laws to ensure that standards of care are followed and do not contribute to dangerous acute episodes of detoxification withdrawal management without necessary linkage to follow-up care, recovery support, or formal treatment, and offer medication for opioid use disorder, alcohol use disorder. Really, just as it states, existing statute does allow for individuals who are acutely intoxicated under alcohol or controlled substances to be transported by law enforcement to providers who provide civil protective custody. But currently the statute is silent on ensuring that there are standards of care that are being met and that individuals are linked to additional services and supports as needed.
My apologies, I'll unmute. Any questions before we move on to the next slide on those two recommendations from members? Nope, okay, great, let's move on to the next one.
Stephanie Woodard for the record again. The next recommendation really is sort of the basis for the presentation that you just heard to establish a statewide and regional overdose fatality review committees to effectively identify system gaps in innovative community-specific overdose prevention and intervention strategies. The next is to modernize Nevada statute that can be interpreted that substance use during pregnancy constitutes child abuse. So currently, we do have a law on the books, and we have heard consistently from national organizations that the way that the statute is worded in current law can be interpreted to state that substance use during pregnancy constitutes child abuse. And we have heard consistently from women who have used substances during pregnancy that fear of prosecution during pregnancy has prohibited them from engaging in treatment. So it really is a fear that many women have about engaging in care when they are experiencing substance use issues during pregnancy. Next one is to require all jails and prisons to offer all 3 medications for opioid use disorder. The next is to continue to update Nevada's revised statute to reflect the importance of public health interventions regarding harm reduction. There have been many opportunities to progress some of this legislation. There were changes in the 21 session to exclude the use of fentanyl and analog testing from the definition of drug paraphernalia, and to provide immunity for individuals who in good faith support an individual in testing their drugs to identify toxins. Further potential policy changes could provide protections for harm reduction interventions to allow for the distribution and protections for persons who in good faith engage in harm reduction interventions.
Okay, thank you for that. A lot to cover there. And let me open it up to members. Thanks for putting your video on. What are your, do you have any questions for Dr. Woodard in regard to the recommendations today? Yes, Dr. Kearns.
Thank you. It's not really a question, but in terms of the recommendation on establishing a statewide and regional overdose fatality review committee, I appreciate the presentation, the comprehensive presentation that Elise Monroy did. I think that we do need to do a little homework on that, because I think we may be missing some populations if we do it out of either the suicide fatality review or bring the other fatality reviews. And an example I thought of was deaths of people involved in DUI motor vehicle accidents. That may be a population that we're missing. And from everything I've seen, I don't have the exact reference, we are seeing an increase in deaths from DUI related accidents throughout the state.
Thank you for that. Dr. Woodard, did you have something to add?
I do. I also very much appreciate the presentation by Elise and her taking the initiative to pilot an overdose fatality review. But I have similar concerns, especially knowing the work, the intensity of the work that is undertaken specifically on the suicide fatality review committee, that I believe that the work for an overdose fatality review committee, while associated, and certainly do agree that there are touch points to all existing fatality review committees, that the scope of the issue as it relates to overdoses may warrant its own overdose fatality review committee.
Okay, thank you. Good. Excellent point. And it falls into a lot of data sharing in general and data collection. And so when we talk about ways that we could consolidate under maybe main topics and then some subcategories, I'd like to point out that this might be one that could fall under a subcategory, and then some specific recommendations under each. I just had a question, just for clarity's sake for everyone watching. Dr. Woodard, require all jails and prisons to offer all 3 medications, and just wanted to make a notation to make sure I have all 3 and anyone watching does.
It should actually state all 3 FDA approved types of medications for the treatment of opioid use disorder. So that would include medications such as methadone and buprenorphine and naltrexone. But does not need to be limited. So the goal here is that all 3 categories of medications that are approved for FDA are available for the treatment of an opioid use disorder.
Okay, great. I can think of some additional follow-up questions, but we can thank you for making that change. Crystal, I see you editing on the spot, and we can have a chance to dive into that a little bit further. So the last one is me. I made a recommendation for establishing a user-oriented searchable website for programs on prevention, treatment, and recovery and response for all substances, essentially a clearinghouse for individuals in the public actually seeking more information. For example, everything from I want to have somebody come and present to my charter school or to my boys and girls clubs. Do we have somebody who is going to present from a prevention standpoint using evidence-based best practices? And then if I'm looking for a treatment specific for alcohol, what are some of the resources in my area? If I'm looking for a treatment, I am a mother who is pregnant and I'm looking for treatment specifically for the situation that I'm in. What's a way that we can connect people? And we've had conversations about, some of the various resources that are available today through 988, for example. But oftentimes we may not pick up a phone and call someone. We may want to just do a search online. We may be able to use algorithms to help to identify individuals that might be searching for those and direct them towards some sort of portal. I will admit that this is probably something that will end up in the for further review category. I know that we do have some of these resources through the state currently. So kind of like the conversations around data collection and review, this may be a matter of just breaking down some of the silos and bringing everything together into one shared resource. But I didn't want to leave this discussion without including this, because I do know that it can be extremely difficult when you're in that crisis situation and you have this window of opportunity where you are looking, and reality is that we do use our computers or laptops or even the community library desktop that's available to the public, to just be able to search and find something that's user friendly for the public. I think that knowing something that's vetted throughout the whole state would be beneficial. So we might put that in the for further discussion category, but I didn't want it to go unmentioned. Any questions for the chair or comments? Okay. All right, so not seeing any questions in that regard. Let's go ahead and move to the recommendations that we've already had a chance to see in previous meetings and answered polls. Thank you to all of you for participating. Thanks to Crystal for keeping us on task, me in particular. I think I was the tardiest in the response to my prioritizations. And so what we did, just so you know, is we had each of the members fill out a poll of all the recommendations that we've had thus far in discussion, or even from the presentations that we've received. We've had presentations from the Sentencing Commission Department, from HHS, and other entities. And so we asked to have each member prioritize their top 5. And then what we had was essentially a rating method that whoever got the most, whichever recommendation got the most hits, if you will, as a priority recommendation is listed first. And then we go in descending order from there in terms of the number of recommendations from that point on. And so what I'd like to do is go through each one of these very briefly. Again, we've only got about 20 minutes left. So I will, for the sake of time, I'm going to read through them, and I'm going to read through, and then at the end of each slide, I'm going to open it up for any questions or comments to make note of, so that when we do a deeper dive in our September meeting and start to take action on these, we have some preliminary questions and comments. So the first one that had the most hits we had 4 members who prioritized this first priority recommendation in their top 5, and that is to amend NRS to assign lengthier prison sentences to dealers that sell fentanyl with or without knowledge in the state of Nevada. If a dealer's drug sales are directly correlated to an overdose event, fatal or non-fatal additional charges should be applied. Trafficking weights of fentanyl should also be lowered to previous law standards. So this law those rates were changed in the 2019 legislative session. And the recommendation that has been brought up by several presenters and stakeholders and subject matter experts in this committee has been to go back to the pre-2019 rates for the weights and the penalties that are attached to them. And so that was our number one priority in terms of the most members noting that as a priority. The next one is for crisis outreach response teams, similar to or enhancing most ACT lead teams to respond to any suspected overdose, and offer follow-up support, referrals, and services to the individual and loved ones for up to 45 days after the overdose. Teams to be dispatched to anyone being released from an institutional setting who is being discharged post-overdose or suspected overdose. And we had 2 members who listed that as their number 1 or number 2 priorities. And so that's what landed that on that first slide. And then the third one on this slide is reform criminal justice services to include the medically assisted treatment, peers, social determinants of health, harm reduction strategies, reduce criminalization and punitive practices towards individuals with opioid use disorder. And there were 3 members who prioritized that. And I will note that that's one that includes a lot of different categories, and a lot of those categories where we can see some repetition in later recommendations that we could consolidate and parse out separately. So first slide, comments and questions in regards to these. And if you were the recommending member, I would solicit you to help respond. Yes, Dr. Kearns.
Yes, my comment was going to be, I wonder, and I've seen some legislation where there are multiple issues within one. So for example, the amend NRS to assign lengthier prison sentences, the first one, I've seen some legislation out of Colorado where they did that within theirs, but they also talked about their Good Samaritan laws, and that if someone acting in good faith and didn't know there was fentanyl, for example, in the pill. So I don't know if we could somehow combine that. And then also in the third one, reform criminal justice services to include Matt. I feel like we could include Dr. Woodard's about the FDA approved Matt.
Excellent observation in regards to ways that we could consolidate. That also crossed my mind, to be able to refine Dr. Woodard's recommendation on the FDA approved MAT. And to answer your question, yes, it is certainly possible to have, and I know the Attorney General has asked for recommendations for BDRs. And oftentimes what we'll see out of the Attorney General's office is what we call that omnibus bill that can have multiple segments to it that would incorporate more than just one of our recommendations, but related recommendations, as long as they're all under the same subject matter. That is absolutely a possibility and one of the potential outcomes of the recommendations of this committee. I do want to acknowledge, and I apologize for not acknowledging our additional representatives from the Attorney General's office. Jessica Adair, I know, is on, and I see an extra name attached. So I think congratulations, it might be in order. But I've worked with Jessica in the past on other legislation, including some omnibus bills, and have always found just been so impressed by the competence of the staff at the Attorney General's office. And I did see a few others. Forgive me for not being able to call out specifically the other members of the team here, but I did notice that some other members of the AG's office are here. So Dr. Woodard, you have your hand raised as well. I'll pivot to you. Questions or comments on these slides?
Thank you, Chair. Stephanie Woodard for the record. As it relates to bullet point number 2, the crisis outreach response teams, Nevada Medicaid received a CMS mobile crisis planning grant, and we are currently working our way through that grant. What will occur after that is a state plan amendment, and we will be developing designated mobile crisis teams that are required to meet specific standards so that we can make use of an enhanced federal match through Medicaid. And we have been talking about infusing some kinds of services within those teams. So just wanted to bring that to everyone's attention. One of the major issues that we will run into is if we have specific crisis outreach response teams, there may be some kind of, there's the potential for policy conflict and financing conflict with the efforts that are already being undertaken as it relates to mobile crisis teams within Medicaid. The second issue that I just wanted to bring up also was that this past week, the Joint Interim Committee on Health and Human Services did decide to work session a potential BDR that does directly address medication-assisted treatment within criminal justice settings, so incarceration settings, including corrections and jails. And I know that part of the conversation that we've had in these meetings previously is to make sure that we are deduplicating efforts and potentially really rising up to a level of prioritization, those concepts that are not otherwise being considered by other bodies.
Thank you. And I agree. So when we're having the discussion about which ones we want to elevate to our top priorities, let's make sure to read the minutes in our next meeting, which will include that comment from Dr. Woodard that this may be one that is already underway, and we can add a footnote that we are in support, but may not want to elevate that into one of our top priorities at this point that isn't already being addressed in some other category, or find a different way to focus on what maybe still needs to be addressed. Excellent point. Okay, so moving on to the next slide, unless I have any others. I don't see any other hands raised. So the next slide, we have 5 more.
Chair, I'm sorry, I couldn't find the icon to raise my hand. So
that's okay. Yes, please jump in.
Thanks. Just Christine Payson for the record, reference changing the NRS. I like what Dr. Kern said, and I think it's going to be a lot better received when we're we're trying to address the deadliness of fentanyl, but still straighten out any discrepancies with the Good Samaritan law. And I just hope that when we look at the verbiage for anything related to this, we're looking at what's going on in our state. All due respect for the great presentation from Lisa, and I really want to do my homework on the report that she referenced, but the information that I'm getting from my director is, as far as Nevada goes, there's been 4 drug-related homicide cases. Each of those defendants has been Caucasian. So at least in our state, this is not something that we have data to show disproportionately affecting people of color.
Thank you so much. And you're right, we always want to balance out examples with other states, as well as overall aggregate statistics for the nation, and compare that with what we're specifically seeing in our state here when we make those decisions. So always appreciate that, that reminder. Moving on to the next slide. So these, we have 5 more recommendations here, and several of these landed in members' top priorities, and then some of them had more than one member listing it in their top 5 recommendations. Increase targeted naloxone distribution. One person noted that as a top priority. Harmonize criminal justice and public health responses to promote access to treatment and medical care. One person had harmonizing as their top priority. And I would say that we've had a lot of discussion about how do we balance out the public safety and the public health needs. That's more of an overarching, I would say, value or goal that specific recommendations can follow into. And next is funding for an independent medical examiner for reports that verify the specific cause of death in overdose cases where the source of the drug supply has been identified and can be prosecuted. That's one person listed that as a top priority. Coordinate with specialty courts to provide front-end comprehensive evaluations to determine co-occurring disorders and provide comprehensive treatment. One person included that as the high priority. And then the last one, we had 2 people identifying it as in their top 5, and that's identify which treatments are essential services within the criminal justice system and develop corresponding policies. So do I have questions or comments from members? Okay, I will make a comment that a couple of these can fall into a consolidation category, I think, with some of our earlier recommendations. So for example, again, having access to the FDA approved medically assisted treatments, and funding for an independent, I did have a question, funding for an independent medical examiner. How might that fall in line with our other priority to have a, no, that's not the one I'm looking for, the overdose fatality review committee. One of the questions that I'd like to discuss in our next meeting would be how that might be one that could complement one another. So we'll just make a note of that. Any other questions or comments on this one? Okay, all right, moving on to the next slide. Standardized data sharing agreements between public safety and public health, a theme we heard a lot of today, that supporting data sharing and allow for re-disclosure to inform risk messaging. Collaborate with the coordinating council, other stakeholders and partners to collect data. Again, that data sharing. So I will say the standardized data sharing, 3 members prioritize that. 2 people prioritize collaborating with the coordinated council. 1 person prioritized a statewide forensic lab. 1 person prioritized funding for API for the OD MAPS system. And 1 person prioritized policy change to cover non-pharmacological or complementary treatments for pain, also to increase coverage for preventative and non-pharm CAM modalities. So comments, questions, or recommendations for how we might consolidate some of these, Dr. Kearns?
Yeah, I just wanted to provide some updated information on the recommendation about funding an API for the ODMAP system. The Attorney General's office has been in communications with Nevada HIDA about getting that funded as either a supplemental funding or a funded line item through HIDA's budget. So that may be something that we don't need to address because will be addressed elsewhere.
Okay. Thank you so much, and please keep us posted on that. By the time of the final publishing of our report, that will be helpful. Okay, any other comments about where we might find opportunities to consolidate here? We do see data a number of times. If you have suggestions, that is something that I think we are permitted to submit those, what your suggestions would be to consolidate some of these. And we will work on with our staff and our consulting team to continue to consolidate and then report back and make that publicly available in the next meeting for sake of discussion. All right, I do want to point out, actually, if we just go back a second, I do want to point out that the policy change for non-pharmacological or complementary treatments is not something we've had a deep dive discussion on from subject matter experts, but certainly one that is worth pursuing perhaps for further review. And the statewide forensic lab, I think, is also something that stands out that we haven't had a lot of discussion on. So I want to make sure we save some time for that in the next meeting, and also see where some of those might fall into some of our existing recent funding for state labs. Dr. Kearns.
Yeah, I'm not sure who came up with the statewide funding for a forensic lab, but I don't know if that could fall under the standardized data sharing agreements between public safety and public health, to have the data that's being looked for the surveillance sampling to be part of that data sharing that exists already in our forensics labs that cover the state.
Okay. Thanks for that question and comments. Dr. Woodard.
Thank you, Chair. Stephanie Woodard for the record. So just to follow up on Dr. Kearns' comments, I'm wondering, as you're talking about consolidation, if we wanted to use a broad term around surveillance and include the overdose fatality review, the recommendation as it related to the independent medical examiner, as well as data sharing agreements in the statewide forensic lab. I think if we take all of those in totality together for future discussion in a next meeting, that may be one way that we can consolidate those concepts.
Excellent. I concur. I think taking some of these, finding those themes and then grouping them will be helpful for expediting our discussion and really helping us to focus on what we need to, ask more questions about and make our decisions. Okay, so if we can move on to the next slide, please. And this is our last slide for discussion of our priority recommendations. It involves 3 recommendations. Each one was from one member. One person prioritized it in their list of top 5. Funding for additional police overdose response teams to respond to and investigate overdose related crimes. I could see that falling into 2 different categories, the mobile crisis response as well as the surveillance. So we can have some discussion on that. Implement follow-up and referral with linkage of care for incarcerated and court-involved individuals, and pain education and awareness at the community level for all age groups. Any of the recommending members want to expand on that, or any members have any questions or comments on these last 3? Yes, Dr. Kearns.
Thank you. I was just wondering if the implement follow-up and referral with linkage of care for incarcerated and court-involved individuals, go along with the one we talked about earlier with the most and fast, or the criminal justice, the public health and law enforcement. So some potential areas where it could be linked in.
Yep, I would agree with that. Christine Payson.
Thank you. As far as the additional overdose response teams, just that there is one, at least in Clark County. There's just one team on Las Vegas Metro that handles all of those. So their parameters for what cases they can triage is very limited. So if we had some more, they might be able to look into some more of these cases. And then we're also looking at, and in discussions with public health, on the linkage to care aspect that could follow up to those calls that the overdose response teams actually are responding to. We're not sure how it would look. We certainly wouldn't want someone from public health showing up at the time of an active crime scene, but trying to find a way for short-term follow-up for their survivors, the family, to get that linkage to care if they so choose.
Okay, thank you for that. Dr. Woodard.
So Stephanie Woodard, for the record, I just wanted to add on to that there is quite a bit of effort going into establishing Nevada's crisis response system, specifically for individuals who are experiencing a behavioral health crisis. And I think there may be some intersectionality with what Christine Payson was just talking about and those efforts. And so would like to just flag that for us as part of the discussion for the next meeting.
Excellent, thank you so much. So that concludes our overview of the recommendations that have been prioritized so far. We want to make sure that as we look through this, is there anything that we're missing? And I would point out that we did hear some presentations today in regards to particularly children with parents who are using substances and prenatal aspects of response. And so I want to just solicit our members. We've got a lot of subject matter experts in this subcommittee. If you have any specific recommendations that you heard from our that or any of our other recommendations today, we also had recommendations about or at least needs expressed around beds and around housing, and those are ones that have not made it into our recommendations. We also did hear from our overview of tribal community needs and the need for further research, as well as other special populations. So there is still a chance for our members to email in any additional recommendations to make sure that we're addressing all the purviews of this response committee based on the subject matter expert presentations we heard today, or anything else that we might be missing within our categories of recommendations for the response committee. I also want to point out just a couple notes about our SURG role. We don't make direct grants ourselves. We make recommendations to Health and Human Services about how to utilize grants or opioid settlement dollars or state federal funds and so forth. And also that to avoid any conflicts of interest, and I appreciated the disclosures from presenters today, SURG recommendations should be made for general types of programs, and we might point to some as models, but we are not making specific recommendations for any specific program. We want to keep it general so that it can be applied statewide based on what's regionally available and avoid any conflicts of interest. And so I think we have a good overview at this point. Based on our discussion, don't feel that we're ready to take any action to vote on any of these recommendations quite yet today. What I'd like to see us do is to consolidate and group what we have to collect any new recommendations that that we might need to fill any blanks to make sure we're not missing anything. And then we will come back next meeting. We've concluded our subject matter expert presentations at this point. We're going to spend the bulk of our meeting, or the entirety of our meeting in September, going through these recommendations and taking action on them. Any of the ones that we saw today, any that we see consolidated, eliminated, or any new ones to fill in any holes. So unless I have any other questions, I know we're getting at time. I want to close out with our last couple items. Please stay tuned because I do have a couple little announcements coming up. So we'll move on to agenda item number 10, and that is subcommittee leadership. Unfortunately, as the sponsor of the legislation that created this SURG committee as a whole, I failed to put in a slot for a citizen at large to continue on. And as many of you know, I am finishing my term as an assemblywoman in November, which means that I will no longer be able to participate and chair this subcommittee or continue on as the vice chair of the SURG committee as a whole, or remain as a voting member. It does not mean that I'm going away. It certainly doesn't mean that I am going to stop being a resource, being engaged, and very much wanting to see the success of this process move forward and support all the members. But with that logistical challenge, I have recommended that Dr. Terry Kearns take over in my role as the chair of this subcommittee, and we'll be addressing in our next SURG committee as a whole a recommendation for the Attorney General to appoint another vice chair of the SURG committee as a whole. And appreciate it. Please feel free to reach out if you have any questions or suggestions in that regard. So what you'll see in the next subcommittee meeting is I am still with you through November, but what you'll see is that Dr. Terry Kearns and I will be passing the baton and coordinating on that transition for the rest of this process to make sure that we see it all the way through to that January report. And Dr. Kearns, thank you for being willing to help be on that relay race team with me. Did you have anything to add, or does anyone have any questions or comments?
The only thing I'd add is I realize I have big shoes to follow in following you, but thank you for your leadership.
Well, thank you all for just caring so much about this important effort. And then for future meeting dates, we will be sending out a poll. We're hoping we have a poll right here, right now, for members on what the best time is for a standing meeting. We found some difficulty with trying to find a time that we could all meet for this subcommittee meeting. So we'd like to move towards more of a standardized time so that might be a little bit easier to predict and schedule ahead of time. So if everyone can go ahead and fill out the poll right now. Talk about an open process.
We still just have only 2 members that have filled it out. So there's 3, there's 4, and 5. And this actually coincides with our incoming chair's availability. So I think I'm going to close the poll if that's okay. We have what looks to be, oh, there we go. And I'll share the results here. We still will just double check which Mondays, because that does look like the winner, Monday from 9 to 10:30 or Monday from 10:30 to 12. So we will just double check that, but at least we've narrowed it down a bit. So thank you, everyone.
Thank you. I love harnessing the power of technology. So moving on to our number 12, public comments. Thank you all for hanging in there, stakeholders, subject matter experts, members of the public. I'd like to open it for public comment with a reminder that you will be limited to 3 minutes per person. Do we see any hands raised on Zoom? I don't see any hands raised.
I'll raise my hand. I did not disable chat outside of being able to chat with presenters. So typically in our meetings, chat is only used for technical issues, but I did receive a public comment that I wanted to read into the record. And in the future, I'll be sure to make that note. And I'm going to read it as it was sent to me. This is from Rhonda Fairchild. I have to go to another meeting. Thank you for the presentations. I'm not sure if I can give public comment to you. I would say that when working with hospitals and ERs, I have found that the policy needs to be written in the hospital or ER guidelines, or the nurses and doctors will not call for help when treating a person with an OUD.
Excellent. Thank you so much thank you, Rhonda, for that public comment. And thank you, Crystal, for including that on the record. Okay, I still don't see any hands raised. Certainly welcome to unmute if you can't find the hand button and call out to the chair. Do we have anyone who is participating on phone that wants to submit public comment? I don't see anyone. Okay, with that, I'm going to close public comment and thank you for hanging in there a few extra minutes past our deadline. I think we did an amazing job getting through all of that. I have to say, well done to all the presenters and the members. And we will see you again in September. And with that, I'd like to adjourn this meeting.
Thank you. Goodbye.
Thank you.